Hello friends, my name is Dr. Arvind Vatkar. Today we'll be talking about degenerative spondylolisthesis. So let's get started. So what is degenerative spondylolisthesis? Basically, this means that there is a slip. Now this is a normal healthy vertebra in which one vertebra is stacked on another. So what happens in degenerative spondylolisthesis is that the whole one vertebra slips over the other vertebra with the junction at the intervertebral disc. Now it is different from an ischemic spondylolisthesis where there is a fracture at the pars interarticularis and then there is a slip forwards. So in degenerative spondylolisthesis, it is basically slip of one vertebrae over the other and there is separation at the facet joint rather than at this in pars interarticularis, and there is compression of the nerves and the dural sac subsequently. Now let's get back to the demographics. So male is to female ratio in this is it is 6 times more common in females rather than in males. This is basically because of the ligamentous laxity, and as menopause is reached it increases chances of spondylolisthesis. It is more common after the 5th decade of life. In prevalence, based on different papers, in males the prevalence is about 2 to 19%, but in females it is high of about 8 to 25%. The most common level which gets which has spondylolisthesis because of degeneration is L4-5 level, which is followed by alpha S1, and the third one is L3-4. Now, what causes degenerative spondylolisthesis? So there are four main reasons. The first is the disc in between the two vertebrae that gets degenerated, which causes segmental instability. Again, even the joints which are on the back side of the vertebrae, which are known as the facet joints, they get arthritic and they start having fluid inside them and the capsule gets stretched. Third is the ligaments which are present behind in the spine, basically the interspinous ligament, the PLL, the ALL, that component fails. And lastly, the muscles, the paraspinal muscles, they fail and they provide inadequate stabilization, causing degenerative spondylolisthesis. Now, what are the risk factors which are associated with spondylolisthesis? First, as we had mentioned before, is the age more than 50. Second is sex. So females are more prone to have degenerative spondylolisthesis. Now, studies have shown that occupational driving of more than 4 hours or intense physical work or contradictively sedentary lifestyle has high chances of degenerative spondylolisthesis. Based on the radiographic parameters, if you have a high PI, that is a pelvic incidence, or if your L4 inclination angle is more than 11 degrees, so if the shear force between the L4 and the L5 is more, then the chances of you having an degenerative spondylolisthesis slip is more. Also, if the facet joint angle, which is an angle between an midline and the angle subtending of the facet joint, if it is more than 60 degrees, then you have a high chance of a slip of degenerative spondylolisthesis. In terms of the symptoms, you might have compression of the nerves, which can cause radicular pain. You might have compression of the dural sac, which can cause neurogenic claudication. Again, the facet joint in the back, they get arthritic, which causes pain in the lower back. And in the late stages, when there is significant compression of the dural sac, then it can cause weakness and gallbladder symptoms. In terms of the investigation, if a patient comes to us, we generally do standing X-ray, which are weight-bearing X-ray of the lumbosacral spine. And in AP and lateral, here you can see there is a mild scoliosis and there is a slip of this L5-S1 junction. Again, if we do a flexion extension view, here you can see in extension that the slip has corrected, but in flexion view you can again see that the slip has manifested. Hence a flexion extension view is very important. Here you can see at L4-5 level on MRI, we can see there is a slip and there is compression of the dural sac. And on an axial image, we can see that the facet joint have got arthritic and there is a lot of fluid collection in these facet joints, which suggest arthritis and instability. In terms of the classification of degenerative spondylolisthesis, this was done by the Meierding's classification, in which grade 1 is less than 25% of slip of the length in of the vertebra. So here, if you divide the vertebra into 4 parts, so if it is less than 25%, it is grade 1. If it is between 25 to 50%, it is grade 2. If it is between 50 to 75%, it is grade 3. And grade 4 is more than 75%. And there is one more grade 5, which is a modified Meierding's classification, in which the superior vertebra actually falls down and it goes below the inferior vertebra, which is known as spondyloptosis. So here studies have shown that the maximum of the cases come in grade 1 or grade 2. Now, what happens generally as a natural history in degenerative spondylolisthesis is, well, you will have pain and radicular symptoms. Sometimes, if the disc the degeneration, the slip auto stabilizes, and basically this happens if the disc height goes less than 80%, and with osteophytes forming, it kind of stops the slip, and then your chances of progression of the spondylolisthesis decrease. However, there is no correlation, again there is no correlation between the radiological slip and the symptoms. The patient might have a small slip and significant symptoms, and sometimes the patient may have a massive slip with no symptoms at all. So now what are the treatment options? So first and the most common is non-operative treatment, which goes for the majority of the patients, in which we give pain medications, we give core muscle strengthening exercises, and we give sometimes epidural steroid injections. Now in terms of the operative treatment, the traditional way is decompression, and generally these spondylolisthesis are fixed. However, even if just a decompression is done, that also has been shown to have equally good results. So the fusion, if it is done, it could be instrumented or it could be non-instrumented. Here you can see there is a non-instrumented fusion in which they have decompressed it, and the bone graft has been laid down, which causes a non-instrumented fusion. And this is the instrumented fusion, in which we have put a cage inside the intervertebral body, intervertebral disc, sorry, and we have put pedicle screws to fix. Now there is a minimally invasive way, which is known as a MIS way, in which the cage is put by a small incision, and the dural sac is decompressed, and the screws are put by percutaneous way. Lastly, the non-posterior approach. These are the lateral axis approaches, by which an oblique lumbar interbody fusion or an extremely lateral interbody fusion can be done, and the screws can be put from the posterior percutaneous way. Lastly, there are some controversies in terms of the treatment. So in terms of the non-operative treatment, the treatment is fairly stable, like fairly standard in terms of exercises. These are flexion based exercises rather than extension based exercises, which could actually exaggerate the slip. And we need to do more of core and postural strengthening exercises like plank exercises to get the paraspinal muscles strong enough to prevent any further slip. In terms of the operative treatment, so decompression plus fusion has been a standard treatment. However, and it has been shown that fusion causes better outcomes, but these are outcomes mostly in terms of in terms of the pain, and it causes better fusion at that level, but there has been no statistically significant difference in terms of the outcomes based on the paper in the Spine Journal by Martin et al. However, instrumentation increases the chances of fusion, but there is no change in the clinical function if it has been either fused or not fused. In terms of the posterolateral fusion and transforaminal interbody fusion, Kelly et al. In the journal in 2019 has mentioned that is no added benefit. So Chan did an study in which he found out that instrumentation improves fusion. However, the clinical outcomes are not too different if it is instrumented or not instrumented. Minimally invasive spine surgery, in the same paper, Chan et al. Has mentioned that it causes less blood loss, less is the cost. So this is a contradictory statement. So generally people think that minimally invasive spine surgery is more costly. However, if you see the whole uh, treatment cost, it is actually less and it causes less hospital stay. Thank you. Thanks a lot.